Okay. Hello, dear college and all participants. Good morning. Now we come to symposium, general symposium number 4 concerning of dissemination of pancreatic surgery. The symposium discussion will be proceed later after all of speakers presenting his paper. And if you have a question, please fill or write your question on the message chat or chat column. As first moderator, I'm with co-moderator Dr. Krishnan from Malaysia.
Morning, Ronald.
Hello, Dr. Krishnan.
Good.
Before we go start, I would like to introduce the first speaker. Please. We have 3 speakers today, but the first speaker is Dr. Martin Smith from University of the Witwatersrand, Johannesburg. He has education undergraduate, University of Witwatersrand, Johannesburg, and until now, he has a lot of experience. And now he is professor of surgery and academic head and chairman of the University Department of Surgery, and until 2021, he is head of hepatopancreatic biliary surgery unit at CHBHH. And Dr. Martin will present his paper. Please, Dr. Martin, your topic is clinical governance and pancreatic surgery. The time is yours.
Good day, my name is Martin Smith. I'm from Johannesburg, South Africa, and I'm going to be presenting on clinical governance and pancreatic surgery. I have nothing to declare. I want to begin with a definition of clinical governance, which is an integrated system through which health service organizations are responsible and accountable for continuously improving the quality of their services, safeguarding high standards of care, ensuring the best clinical outcomes, creating an environment in which excellence in clinical care can flourish, and integrates the perspective of staff, patients, their carers, and managements. The requirements are not complicated. It requires commitment at all levels, an organizational culture, procedures and practices, and effective teamwork, because effectiveness of care is not an isolated professional matter. Systems of clinical governance are well established, and they're all forms of audit, morbidity and mortality conferences, clinical audits, evidence-based clinical practice and the use of standard guidelines, and measuring clinical performance using indicators or metrics. There are 3 different types of audits in healthcare settings. There's the external audit, used to demonstrate compliance with external criteria such as certification and accreditation. Internal audit to demonstrate compliance with regulations. And then there's clinical audit to improve clinical practice by examining care against criteria and to implement improvements. We are all aware of the clinical audit cycle, and it's used for quality improvement. But to do so, quality of care must be well defined, and these must be based on evidence-based guidelines. Care must be evaluated, and compliance to various guidelines and recommendations evaluated. Lagging compliance must be identified, changes implemented, and feedback is essential. And that's called the 360 degree. I want to just reflect on quality indicators, which do not measure quality directly, but function as surrogate or metrics. So it's important to measure and evaluate beyond quality indicators. Also got to examine the influence of risk factors on these quality indicators, and you've got to adjust the risk profile of the patients and the institution. So the process is usually divided into its outcomes, the structure, and the process. And using qualified criteria to indicate the appropriateness, one looks at relevance, scientific evidence, and the ease of use of the quality indicator. So we're all well aware of the guidelines and definitions in pancreatic surgery. For example, here we have the ISGPF definitions of postoperative fistulas, hemorrhage, delayed gastric emptying, as well as bile leakage. We go beyond that by looking at the ERS criteria and guidelines for pancreatic duodenectomy. And we all use the Clavier-Dinder classification of complications as a standard of reporting. So when we are looking at clinical governance in pancreatic surgery, what is it that we should be measuring? We're going to look at a number of studies, national studies, to give you some idea of what some of the criteria are. This Dutch pancreatic cancer audit was a very important study because it covered all 18 hospitals in the Netherlands who were doing pancreatic surgery. They used a complex process which required review of the literature, sometimes Delphi review of experts, and systematic reviews. And they divided their indicators into performance indicators and case mix indicators. And in each one, there were a number of criteria that they looked at to determine the suitability of outcome. All aware of the NESQIP process from the American College of Surgeons. It's a prospective multi-center clinical registry that was created to provide feedback on risk-adjusted outcomes to hospitals for quality improvement purposes, hence clinical governance. What's important to recognize here is that this wasn't a national study because it didn't include all hospitals. However, they did identify 20 preoperative variables that were significant in predicting postoperative outcomes. And they reduced this to 10 easy accessible clinical parameters to assist in making informed decisions by creating a calculator. And these are the 10 criteria that they looked at to determine mortality and morbidity. The next study is one from Germany, which I think is a really important study because it looks at clinical governance in more depth. This study looked at 3 areas of evaluation: clinical quality, process quality, and structural quality, which are 3 areas that are common to most registries and evaluations of outcome. Clinical quality looks at things like mortality, readmission, complications, whereas process quality looks at preoperative cross-sectional imaging, protocol use of antibiotics and thromboprophylaxis, and issues around the actual surgery and the treatment. And structural quality looks at the availability of interventional radiology, intensive care units with specially trained personnel and multidisciplinary teams, etc. They then looked at 5 quality indicators and gave reference values for them and gave target reference values and used these as an important measure of their outcomes. I want to move on now to what I think is an important study that was published earlier this year, which then compared 4 of these registries. 3 of them I've discussed, the one from Sweden I haven't. Serves an external validity of the reports from these registries, and the aim was to compare differences in collected variables, definitions, patient tumor, surgical treatment characteristics, clinical outcomes, and pathological outcomes. And from this table, you can see, while these are all the criteria they looked at, it's about the adherence to these criteria. And you can see gaps in all of these different registries. So they concluded that in 4 Western countries, the design of pancreatic surgery registries differ. Differences in patient selection and characteristics, treatment strategies, outcomes exist, which require further study and improvement. They suggest that harmonizing the registries provides an opportunity to compare outcomes accurately, to set clear benchmarks, combine and extrapolate data from different countries, ultimately reducing variation in practice, which may improve outcomes globally. Now, there is a talk later in this session on centralization, but it's such an important component of clinical governance, particularly in pancreatic surgery, that I just want to highlight a number of issues that I think reflect particularly on the clinical governance. It's a process of concentration of resources, including infrastructure, staff, material knowledge, and research. But it's not based purely on the minimal number of procedures, but rather on the multidisciplinary treatment of complex diseases. High volume institutions are known to be associated with improved outcomes because it's believed they understand the indications better, they are able to perform complex surgical procedures, and their postoperative care is enhanced. Unfortunately, unrestrained, purely market-driven approaches are deleterious to the patients and society in this regard. Hospital volume is a surrogate marker for the quality of the infrastructure and processes rather than the performance of individual surgeons. The surgical community does embrace the principles and advantages of centralization, and the only area uncertain today is whether the threshold of 20 procedures should be increased. So the real impact of centralization on outcomes still remains vague. The determinants of value of centralization are multiple. So is it center or surgeon volumes? We're all aware of the inaugural work of Berkmeyer, which suggested it was surgeon volume. But we're not sure of what the cutoff for that is. The strength of the relationship varies according to the complexity of the surgery and the range of hospital-based services. Increased hospital volumes compensate to a certain degree for low-volume surgeons, but never match those of high-volume surgeons. So this French study, I quote just because I think it was important in trying to identify the cutoff levels, particularly looking at 90-day mortality rates. They identified two cutoffs, one less than 25 resections per year and then 26 to 65 resections per year. This also gives policymakers and surgeons realizable goals in terms of the numbers. The rescue phenomenon is also an important component of the structural relationship of outcome in terms of clinical governance. It's about the value of closed ICUs, board-certified intensivists, the presence of residents, and the presence of better overnight coverage and timely response to when necessary. There are challenges to the implementation, and I think that they reflect to some degree failure of clinical governance. So despite laws and regulations, efficient implementation is not realized globally. The ability to perform complex procedures is not all that we should be looking at. Best patient outcomes through holistic treatment processes are not always prioritized through this process. Again, failure of governance. And the risk adjustment debate with misleading data used by for-profit institutions also does not help us to achieve clinical governance. The European Surgical Association, in a publication in 2018, gave their 12 recommendations for centralization. And I present them here only because I think that they highlight very important clinical governance issues. We've spoken about definitions, case numbers, appropriate resources, networks of hospitals, legal frameworks, audit, research, quality control being essential, and equity of access must be monitored. And lastly, they talk about the involvement of surgical education for specialists as an important recommendation for centralization. So I want to look at education as a driver for clinical governance very briefly. Well-trained staff do impact on outcomes, and the benefit of patient outcomes is well established through a number of studies, suggesting there's a relationship with lower mortality, shorter hospital stays, lower complication rates, and enhanced academic outputs when there is educational prioritization. But unfortunately, there's heterogeneity in the training and accreditation of HPB surgeons globally. There's the issues around balance of training and service delivery, the need for competency across an extensive range of complex technologies that are now needed to perform pancreatic surgery properly. Caseload again becomes an important issue, but there's recognition that some centers of excellence manage predominantly one or another HPB organ-related disease. And so cross-rotations become an important opportunity in training. But there remain challenges to licensure, relocation, and provider privileges. Again, the issue around the case number is not well resolved. But we do understand that equivalency mortality rates for pancreatectomy occurs after 20 cases, and in terms of morbidity after 60 cases. Accreditation of fellowship programs becomes an important form of clinical governance there. Accreditation of practicing surgeons is problematic and is likely to be the most contentious element. The criteria for accreditation of institutions should be more stringent, with demonstration of appropriate educational environment, minimal caseloads, appropriate balance between training and service delivery, and a core HPB fellowship training curriculum. So accreditation and credentialing, I've already said, is a form of external audit. The criteria should focus on the disease rather than the number of procedures. Quality control should also encompass the whole process, including prevention, diagnosis to treatment, complications, survival. There are 3 steps in the accreditation process. There's the self-assessment process, auditing, and then reporting. And this is a summary of the assessment form used by the EHPBA in the accreditation of hospitals in the European African region. And again, looking at clinical issues, procedural and structural issues together. So in conclusion, clinical governance is a systems approach to improving clinical outcomes. Well-described systems of audit determine clinical governance. Prospective data and registries are essential. Evidence-based guidelines are important to develop quality indicators. Better harmonization of data is required to compare and improve outcomes nationally and internationally. Centralization is an important mechanism to ensure clinical governance, and education is a critical component of clinical governance through a process of external audit. I thank you for your attention. Thank you.
Thank you very much, Professor Martin Smits, for your nice presentation. And we go to discussion, but we don't have any question from audience. And we go to a second speaker. Please, Dr. Krishnan, you can take over to moderate.
Yes, okay. Thanks, Ronald. So we get on to the second speaker for this morning. And the next speaker is Professor Fumihiko Miura from Japan. Professor Fumihiko is currently at the Tokyo University Hospital, and he has got extensive experience. He's also a fellow of the American College of Surgeons, Japan Surgical Society, Japan Surgical Association, and many other societies. It'll be too long if I continue to read this list. So I would like to invite now Professor Fumihiko to talk on centralization of pancreatic surgery. Professor Miura, the screen is yours.
It's a great honor to be able to speak to you today. I'd like to talk about centralization of pancreatic surgery in Japan. There are many reports regarding centralization of surgery. However, centralization of pancreatic surgery in Japan has not been clarified. Japanese Society of Hepatobiliary Pancreatic Surgery, JSHBPS, analyzed data from the National Clinical Database, NCD, to elucidate the current status and significance of centralization of pancreatic surgery in Japan. Today, I will present the results of the study. NCD is Nationwide Surgical Database of Japan. The NCD covers 95% of all surgical procedures in Japan. More than 5,200 hospitals participate, and more than 1.5 million cases are registered annually. Firstly, we represent centralization of pancreatic surgery to high-volume hospitals. The JSHPS defined high-level HPB surgeries as shown in the slide. As for hepatobiliary surgery, all hepatectomies more than segmentectomy except lateral sectionectomy, and also extrahepatic bile duct resection for congenital biliary dilatation. As for pancreatic surgery, all pancreatic resection except distal pancreatectomy without lymph node dissection and partial pancreatectomy. This study was intended for PDs performed and registered in the NCD from 2011 to 2012. A total of 70,564 patients were eligible for this study. The 70 patients who underwent laparoscopic procedure were not included. Mean patient age was 68.5 years, and 62% were men. Diagnoses were pancreatic carcinoma in 49%, distal cholangiocarcinoma in 20%, ampullary carcinoma in 30%, and small intestinal carcinoma in 3.4%, and so on. We classify hospital category according to number of high-level HPP surgery performed per year into low-volume hospital at VH 29 or less, medium volume hospital MVH between 30 and 49, and high-volume hospital HVH 50 or more. Number of LVH, MVH, and HVH were 930, 123, and 130 respectively. Of 70,564 patients, 41%, 18%, and 41% underwent PD at HVH, MVH, and LVH respectively. This slide shows outcome after PD according to hospital volume category. 30-day mortality and operative mortality were 1.3% and 2.9% respectively. Both mortality rates were the lowest in HVH 0.7% and 1.7%, followed by MVH 1.2% and 2.9%, and LVH 2% and 4.1%, with significant difference. Rates of the operation, bleeding more than 2,000 milliliters, and blood transfusion were the lowest in HVH. However, rate of operation time more than 6 hours was the lowest in LVH. Total length of hospital stay was shortest in HVH, followed by MVH and LVH, with significant difference. This slide shows post-operative complications. Incidence of any complication was the lowest in LVH, followed by MVH and HVH. Incidences of anastomotic leak, unplanned intubation, and acute renal failure were lowest in HVH. Regarding incidence of post-operative hemorrhage, LVH and HVH were lower than MVH. There are no significant differences in incidences of pancreatic fistula grade B or more, and other complications. Multivariate logistic regression models with hospital volume as a categorical variable that explored yardstick cutoff points of annual hospital volume showed that odds ratio for 30-day mortality was significantly lower in 10 or more and 50 or more category than in less than 10 category. As for operative mortality, 10 or more and 17 or more category had significantly lower odds ratio than less than 10 category. This result indicates that definition of HVH was almost appropriate. Factors affecting surgical outcome are pre-operative treatment, skills of surgical team, critical care specialists, post-operative care, and patient risk. We analyzed post-operative care and patient risk, which could be evaluated by the NCD data. This slide shows failure to rescue rate, FTR. FTR of LVH, MVH, and HVH were 10.4%, 6.9%, and 3.9% respectively. This result indicates that HVH may be stiffer at post-operative care, perhaps due to well-organized multidisciplinary teams. This slide shows perioperative characteristics of patients which were more common in HVH than in LVH. Rates of alcoholic habitually, pancreatic cancer, and preoperative treatment were significantly more common in HVH than in LVH. This slide shows perioperative characteristics of patients which were more common in LVH than in HVH. High age, ambulance transport, ADL any assistance, ASA grade 3 or more, congestive heart failure, myocardial infarction, and hypertension, and so on, were significantly more common in LVH than in HVH. Those results indicate that patients with comorbidities were more likely to undergo PDs in LVH. High proportion of patients with risk factors might be responsible for the higher mortalities in LVH. Next, I will present centralization of pancreatic surgery to high-volume surgeons. JSHBPS established both certification system in 2008 to improve the medical level in the field of HBV surgery, contribute to social welfare, and enable further advances in HBV surgery. The board certification system of JSHBS consists of board-certified training institution, board-certified instructor, and board-certified expert surgeon. Board-certified instructor must be a board-certified surgeon in gastroenterology and have experience of performing 100 or more high-level HBV surgery as an operator. Board-certified expert surgeon must be a board-certified surgeon in gastroenterology and perform 50 or more high-level HBV surgeries as an operator, and 10 or more high-level HBV surgeries as a first assistant during 3 to 7 years training at board-certified training institutions. To be certified, an expert surgeon applicant must pass the video review. Number of expert surgeons and instructors were respectively 12 and 484 in 2011, 30 and 550 in 2012. Both certified expert surgeons or instructors participated in 57% of all cases. This shows outcome after PD according to participation of the both certified expert surgeon or instructors. 30-day mortality and operative mortality rates were significantly lower with participation of both certified expert surgeon or instructors, 1% and 2.2%, than without, 1.7% and 3.8%. Rate of reoperation, bleeding more than 2,000 milliliters, and blood transfusion were significantly lower with participation of both certified expert surgeon or instructors than without. However, rate of operation time more than 6 hours was significantly higher with participation of both certified expert surgeon or instructors than without. Length of hospital stay was significantly shorter with participation of both certified expert surgeons or instructors than without. This ratio post-operative complications. Incidence of any complication was significantly lower without participation of both certified expert surgeons or instructors than with. Incidence of aneurysm leak, acute renal failure, and cardiac occurrence was significantly lower with participation of both certified expert surgeons or instructors than without. There were no significant differences in incidences of pancreatic fistula grade B or more and other complications. This ratio preoperative characteristics which were more common with participation of both certified expert surgeons or instructors. Rates of alcohol habitually, pancreatic cancer, and preoperative treatment were significantly higher with participation of both certified expert surgeons or instructors than without. This ratio preoperative characteristics which were more common without participation of both certified expert surgeons or instructors. Rates of high age, ambulance transport, emergency surgery, ADR before 30-day any assistance, ASA grade 3 or more, hypertension, and previous PCI was significantly higher without participation of both certified expert surgeons or instructors. Those results indicate that patients with comorbidities were more likely to undergo PDs by low-volume surgeons. This study has several limitations. Volume categories were classified based on not numbers of pancreatic surgery, but those of high-level HBV surgeries. Risk adjustment was not performed. Number of both certified expert surgeons was small, and long-term outcomes could not be analyzed. Conclusions. Centralization of pancreatic surgery in Japan has advanced to a certain degree. Mortality rates of pancreatic surgery at high-volume hospitals were better than those at low-volume hospitals. Mortality rates of pancreatic surgery by high-volume surgeons were better than those by low-volume surgeons. Patients with comorbidities were more likely to undergo pancreatic surgery at low-volume hospitals and by low-volume surgeons. Further follow-up study is needed. Thank you for your kind attention.
Thank you, Professor Miura, for that excellent discussion on the centralization of pancreatic surgery. I think it's obvious that the more you do, the better you get, but you have shown that it's also important to have certain characteristics of the surgeons, whether they're experts or actually instructors. I can start off the questions for you by asking, is there a difference between the complexity of the surgery related to the outcomes? For example, if you have vein resection or arterial resection associated with your PDs, are the results better also with high volume centers and high volume surgeons?
I'm sorry, I have no data because TAM classification was not available in 2011.
Oh, okay. The other question I'd like to ask you is, it's very interesting in your last slide in the conclusion, the higher the preoperative morbidity is, the morbidity of patients with the pre-op morbidity patients are done more in the low volume centers. Now you'd expect that this should be a reversal. Those patients with preoperative morbidity possibly should be better handled at the higher volume centers. What is your take on this, Professor?
It is a difficult question. Perhaps due to patient selection. One answer is perhaps patient selection by high volume hospitals.
Yes. So is there a mechanism whereby the selection of patients is done preoperatively, so that if you have a higher preoperative morbidity, those patients are actually sent to the higher volume hospitals? Is there a mechanism in your country?
I'm sorry. It's a difficult question to answer.
Okay. There is a question for Professor Martin Smith by Professor Tua. Prof. Martin, what are the burden in managed the centralization of pancreatic surgery based on government view, and how the private sector role comes into play in this?
So I think that's a very important question because it reflects on the potential for interference in the judgment. So it relates to marketing and to the protection of one's particular reputation. And so when centralization is influenced by those issues, then patient outcomes aren't the focus. And we need to make sure that patient outcomes are the focus. So we've got to put in place mechanisms which avoid that kind of marketing component for determining high volume centers and for centralization. So I think it differs in different countries. It depends on the laws, and it depends on the criteria used, excuse me, to measure those outcomes.
Oh, thank you, Professor Martin. In Malaysia, for example, we have got what is called the National Specialist Registry, whereby surgeons who want to perform hepatobiliary surgeries have to be registered as a hepatobiliary surgeon. And this certification is provided by a group of experts in that particular field. Does it exist in South Africa and in Japan as well?
Yes.
Yes, it does exist in South Africa. I think it forms part of the concept of accreditation and certification, which I think is an important process. I think it becomes, one has to define the responsible body to be able to do that. So should it be government regulation, or should it be a professional association? So if, for example, in the European African region, the European African Association has taken responsibility to start developing accreditation and certification criteria, and then there's an exam that's performed in the European region to certify, actual board certify the surgeons. So again, it's not uniform across even our region, but certainly not globally.
Thank you, Prof. There's a question for Professor Miura. How you assess the competency of pancreatic surgeon for work in the centers?
Adam?
How do you assess the competency of pancreatic surgeons for work in a particular center?
I'm sorry, I can't answer.
Is there any way that the Japanese Surgical Society assesses a pancreatic surgeon? Is there any exit exam, or do you conduct studies to see whether this surgeon is performing up to the mark?
National Clinical Database. Do that.
Okay. There are no other questions at the moment, so maybe Ronald will move on to the last speaker for this session. Yes, is that okay?
I think it's better for you.
Okay. The last speaker probably needs no introduction at all. He is the organizing chairman of this wonderful Bali meeting, Professor Tua Lalisang. I have known Professor Tua for quite some time now, and we were members on the APHPBA committee. And when I saw the title of his talk, I was surprised as to whether he's going to talk on a wheel. Because it looks like the hub and spoke. It reflects to me that there's something to do with the wheel in this discussion. Now, Professor Tua had his education and postdoctoral fellowship at the Faculty of Medicine, University of Indonesia. And Professor Tua, I invite you now to share your experience on the hub and spoke model on pancreatico-duodenal resection. Professor Tua.
Okay. Thank you very much, Dr. Rahman, for your nice introduction, and Professor and Dr. Ronald as the chairperson. First of all, because I'm also the chairman, I'd like to thanks a lot to Professor Martin Smith and also to Prof. Fumihiko from Japan to contribute your experience in this topic. So my topic today are hoop and spoke model on pancreaticoduodenal resection, like a strategy for to build up a pancreatic center. So it is a short slide about my background. It is my hospital and my medical faculty. And we are in Jakarta, the central capital of Indonesia. I work in Jakarta also in the Department of Surgery. As you know, I am the chairman of this meeting, but also the chairman of Indonesian chapter of HPV. Thank you. This is my statement and my layout about this topic. So let I begin that pancreatic cancer is an intractable pain, intractable malignancy, leading cause of cancer of the seven leading causes of global death in the world, in the world, and also became increasing in size, in frequency. The cause is complex and multifactorial, and as you know, mostly the histology type is adenocarcinoma, and if it is not resected, the result will be poor. As we know that the resection is offer the only hope for cure or prolonged survival, and while the candidate for a good resection is only 5 until 12%, and as we know, people is the surgery of choice for head pancreas and left side pancreatic resection for tail and body pancreas. Total pancreatectomy itself, it is already abandoned due to very many cases of severe metabolic consequences. In this slide, you can see that there's the frequency of the pancreatic cancer based on place in the globe continent. In Southeast Asia, there were 2 until 3 cases per 100,000 population per year. So Indonesia is around 7,000 under 10,000, but I think it is the number, it is under recorded because it is not show up right now. It is a long history of the PD resection. It is since the mid of 18th century, and it is famous by Klaus and Whipple. And until now, it has already been the standard procedure for malignant head tumor, or there are also cases in benign cases. The problem is in surgery, I think, because why we show up this topic, because according to 2 speakers before by Professor Martin and Professor Fumiko, we can see that still there are still high morbidity complex and complication. Yes, the operative mortality is already decreasing because I think one of the strategy is centralization of cases, and the perioperative care is better and better. But in the other side, it became also the world-class excellent hospital indicator for hospital who can solve the problem in pancreatic resection. Yeah, we are facing with 5 problems if we are see in this slide that we call for pancreatic surgery. We consider the approach with kind of approach, the minimal invasive, or we will go for the classical one because there are many type of approach. It is already proven that the minimal is can be also safely be done. Also, we are thinking about the referral system. That's why this talk, we make the two type strategy, the centralization, and I like to declare or to show to us that about the decentralization program. Okay, consider about the perioperative management, the positive of complication, and the patient autonomy also, because it is very important for the successful operation. There are strategy in the past before until now that because the poor result, so there are some opinion of nihilism, so not to do something or only make the bypass, but there are some now develop the realism content, the realism, what I mean, realism opinion to make a good surgery based on the data, like what they show by the two previous speakers. And there are also an activism, they make a total pancreatectomy and make stump transplant. Even the diagnostic approach, it is not so difficult anymore right now because there are many good imaging tools and also markers for to make the real diagnostic setting. And as we know that there are already many journals or many publications about this centralization of cases for the pancreatic fixation, and there are, I can see in here that the tight correlation between the volume and the result. Yeah, if in very low, you can see the increasing of morbidity or mortality, and it is becoming down if the high center perform an operation. It is also to make it sure that in any definition, I don't know, by Professor Fumihiko said that what is the definition of high volume, but here itself, I think the high volume we have mentioned if we operate more than 15 cases per year. So we can see there are good also correlation between the output, even in the in-hospital mortality, even or in the 90 days mortality. So I think right now the strategy is what worldwide use is the centralization high volume center, because it is already concluded that it is increased, it is decreased the volume, but the still, morbidity it is still high, but they can also solve and overcome the morbidity. So it will not end it with, mortality. There are centers where they make an operation where the mortality itself it is less than 1% in some center in Europe or in Japan or in Korea and South Asia. Yes. Let's see. It is the experience. It is the same like what's happening in my country, that we also have experience, and it is published in the Journal of Cancer Indonesia that there are a tight correlation also, the similar result with what is published worldwide. And at the same study, we got that the high volume hospital, we make it is as a hub hospital. So now I come to direct to my topic, and the surrounding hospital as the spoke hospital. So we make this study. And from that study, with the strategy of a hub and spoke study, we get the result. The result is make that hub and spoke system, it is one of the choice, because centralization of PD management, it is not centralization, it is not feasible in an archipelago country, because it will be a prolonged time and transportation. The problem is we set the hub and then we send the team to the spoke hospital in the periphery. But the problem is how to measure the competency used of the personnel who will operate in the spoke hospital. That's why I'm asking Professor Fumihiko about how we assess the competency of the surgeon. So according to our data and the references, we use the cumulative summation calculation, what we call, it is a statistical calculation to assess the surgeon competency. So he can do the operation, PD operation by himself. And with this calculation, we got that we need about 42 until 50 times procedures for the surgeon to perform by his own in a good standard hospital for pancreatic duodenal resection, as long the hospital, spoke hospital, have enough and standardized tools and multi-program or multi-specialist board. So with this, at the end, with this conclusion that the pancreatic resection and reconstruction for our study, can be done by the competent surgeon, even it is done in a spoke hospital. And the surgeon itself, it is also trained in the high volume center, like in the Hope spoke. And in the study, it is done in my center, tertiary hospital in the center of Jakarta. Slide, I think a little bit talking about the Hope hospital. It means a center of excellence training the fellow urgent for perform pancreatic surgery in spoke hospital or perform surgery by a center hospital team in a spoke hospital. Spoke hospital is a standard hospital for major surgery with also minimal, there are intensive care unit and multidiscipline program specialist. So with that condition, we mentioned in an archipelago country, it is the pancreatic surgery for decentralization is a fit procedure or fit system. There are some requirements. I think it is realistic that if we like to build up a hub, there must be a agile and mobile, well-trained surgeon, and also a very what we call a patient surgeon to solve the problem of pancreatic resection. In the spoke, as I already mentioned, there are multidisciplinary post-op care and a good surveillance, and we have a very good communication between the hoop and the spoke. Strong network for communication also, and finance support by local, or by central. And I think the strong sense of trust from the hoop to the spoke hospital. There are some risks and barriers. You can see here that the risk is congestion at the hoop hospital, overextension of spoke because they are waiting, the time list also, or the facility, staff dissatisfaction because you know there are also other people, external people come to their places, and maybe there are some from distribution. The barrier will be the lack of established healthcare, and in fact, very important is about the funding, the poor social acceptances about the surgery itself because there's no time to talk too much to the people there. Lack of well-trained HPB surgeon. I meant here the well-trained for the pancreatic resection, and also geographical feature because even it is the archipelago, there are where the islands is not flat, but there are many mountain and problem with transportation or communication also. So, Mr. Chairman, ladies and gentlemen, and all the participants, according to my talk, I think I like to end my talk with mention that the hook and spoke system or the decentralization system is compatible in archipelago country like Indonesia, and maybe it is also compatible for any places where not an archipelago, but it's a country, a very large country. I don't know, I have already visited Professor Martin's places. It's also a very large one, and maybe this system can be performed there. because the aims of the important point is to deliver the surgery services to closer to the patient or to near the patient, not patient bring to the centralized to the center like what centralization was performed. That is my talk, and thank you again for all of your attention.
Thank you, Professor Toa, for that excellent discussion on hub and spoke model. Now, in Malaysia, we have, for example, we have about six hospitals which you would consider hub centers where we perform pancreatic surgery at a high volume. And we never used to have spoke hospitals before because the transportation in our country is easy enough to refer patients to the hubs. However, in this pandemic, with the outcome of this pandemic, the major hospitals in our country were closed due to the lack of ICU beds because all the beds were filled with COVID patients. And here, I think we modified your spoke model. We sent our surgical team out to the smaller hospitals, which had available OT time to perform surgery. Now, we know that pancreatic surgery, the very important thing is not the surgery itself, but the post-operative management. So how do you train the spoke hospitals to, in terms of post-operative management?
Thank you, Dr. Rahman. I think it is the same. And this kind of idea, it is also got up because of the pandemic situation also. But direct to mention the criteria, in the firstly, we make a good communication. So they must report the complication or every condition of the patient post-operatively. And as I mentioned, the spoke hospital must be standardized, what we call to make a major operation also. So the spoke have a multidisciplinary specialist board, and also support by the important thing, the imaging or the radiologic and intervention radiologic or gastroenterologic to take care about the. But if the problem is happening and we need to go back, the team from the Hub hospital will go there. That is my opinion. Okay.
Thank you, Professor. Over to you, Ronald. Is there anything else that you would like to ask any of the speakers, or are there any other questions?
Yeah. Thank you. I would ask to Professor Toa Lalisang. It's very interesting to build the spoke hospital, especially in Indonesia. You know that Indonesia have some archipelago country. So the important thing is in spoke hospital we have to the hospital has to well-trained pancreatic duodenectomy or surgeon. So who is take a responsibility to have to make the surgeon to be a well-trained surgeon?
Yes, thank you. Ronald, thank you. It's very nice question, and it is challenging one. So usually, as a Hub hospital, like in Indonesia, we train the pancreatic surgeon or the fellow. Usually, we based on the digestive surgeon, but we make like a fellowship in the pancreatic surgeon. It is my plan. And what is already done like this. So usually they come to assist us and also to join the fellowship like that in the pancreatic surgery. And like I mentioned you, again, according our calculation, why we use the Symposium cumulative summative calculation, it is a statistical tools. We got that after general surgery or after general digestive surgeon, if he work and exercise with 50 cases of pancreatic resection, we decide that he can perform the operation in the spoke hospital by himself. with a good team who he arranged. So I like to point out that he is not only the skill of pancreas, but he must work in a teamwork system. So using his or her training, he also work in the what we call the team of pancreas or liver resection team. That is the important thing. So if I like to, can I ask direct to Professor Martin or Professor Fumiko, for both of you, that yes? Oh, time is over. I don't know. One is question only. Like Professor Rahman said, that it is not only important the skill, but how you set up the hospital. Because I understand the surgeon, he can operate, but if he operate in a standardized hospital, it will be also influence the outcome. What is your opinion, Prof. Martin and Prof. Fumihiko?
So I think that what you're reflecting on is the systems approach to pancreatic surgery. And so I think that that we're not sure from the evidence whether it's the hospital volume or the surgeon volume that's important, and it probably both. So my only comment here would be is, while I think in countries like yours and certainly like mine, where you have to develop skills, what's important to link to the hub and spoke model is the transfer of skills. So it's about preparing these hospitals to eventually be able to do this themselves without us having to go there. And I think that that's the big challenge, that we must link what you're doing to empowering hospitals to be able to eventually do it themselves, and not to see this as a permanent solution.
Thank you.
Any other comment from Professor Fumihiko about Professor Toar question?
Thank you for your nice presentation. As Indonesia, I think also in Japan, patients with comorbidities may undergo PD in the low volume hospital, perhaps due to traffic conditions, I think.
Okay. It's very interesting because Professor Fumihiko talk about centralization, and Professor Toar speak about decentralization. It's very interesting. Okay, maybe from Dr. Krishnan, before we close the session.
Yeah, thanks, Ronald. I think it's very important that we develop the skills, not only in the surgeon, but the entire team should be competent enough to manage. Like Professor Martin Smith alluded to earlier, it is the failure to rescue, which is important in pancreatic surgeries, as we all know. So we need to have a competent multidisciplinary team to manage these patients on a holistic basis. And with that, Ronald, I think we come to the end of this session. So yeah. I leave it to you to close the session, Ronald.
Okay. Let's make a photograph picture. Picture first.
Okay.
Virtual picture.
Okay. Before we close, maybe from committee, please take a photography before I close this session. Okay.
Done.
Thank you very much for all speakers for your nice talking about this dissemination of pancreatic surgery. Thank you very much again, and see you.
Bye,
Thank
Ronald.
you, Dr. Krishnan.
Thank you, and goodbye to all.
Goodbye.
Thank you. Bye.
Bye.